All right, page 368. These are known as the SNRIs. They work by decreasing the neuronal reuptake of both serotonin and norepinephrine and more weakly inhibited dopamine. Look at this, guys. It says this classification of medications may be more effective for treating depression than other antidepressants for some people. So even though our SSRIs is our first choice for treating depression, if they don't work, this is another option that works for other patients. They may even be used before MAOIs or TCAs due to fewer side effects. That's important for you to know. As with other antidepressants, these drugs have a black box warning to be alert for the possibility of increased suicidality, especially in children, adolescents, and young adults, which is crazy because we're giving this med so that they're not depressed, so they don't try to kill themselves, right? The 4 SNRIs are, and you guys see the list, I'm not even going to try to pronounce these drugs, but make sure you know them. Therapeutic actions and indications. The SNRIs increase the levels of both, this is the second time we're seeing this, guys, of both serotonin and norepinephrine. They do not inhibit MAO. They often will have therapeutic effect for 4 to 6 weeks. And guys, that's across the board. All of these drugs for depression, these psych drugs, it takes several weeks before the patient will have a therapeutic level in their system. So it's very, very, very important to teach the patient beforehand. They're not even going to start feeling the effects until a solid 4 weeks minimum, okay? Client assessment. It's important to know whether the client is in the process of quitting smoking. Wellbutrin, this drug's effective in clients undergoing smoking cessation. So if you have a patient that needs an antidepressant, but they're also a smoker, do we ever want our patients smoking? No, so we're going to encourage them to stop smoking. This is a great medication that you would expect the doctor to order because it's going to help with the depression, but it's going to also help them get off of the tobacco, the nicotine. Contraindications and cautions. If they're allergic to the SNRIs, drugs should not be used in conjunction with MAOIs due to risk of hypertensive crisis and serotonin syndrome. You guys need to know that. Caution should be used with severely depressed patients or suicidal patients because remember, an adverse effect of this drug is causing them to want to kill themselves, okay? Especially in children, adolescents, and young adults. Patients should be screened for bipolar disease and the risk of seizures before starting these medications. Yeah.
Question regarding that. So is the patient supposed to, are those suicidal ideations supposed to decrease after the therapeutic levels reach, or as soon as they say, when they're beginning the treatment?
It's supposed to decrease after the patients reach the therapeutic levels, but the problem is, if they're acutely, at the moment, let's say we have them Baker-acted because they're suicidal, we have to be very careful because this type of drug can actually throw them over the edge and make them want to kill themselves. Does that make sense?
Yes.
So it's really good for those patients that have chronic depression they're being maintained. But those that it's acutely active right now that they're already suicidal, that patient's going to be on that one-on-one. I mean, even to the bathroom. You're going to the bathroom with them. You're not letting them close that door and being there alone. Adverse effects. Some of the most common side effects are nausea, constipation, higher heart rates, hyperhidrosis, erectile dysfunction, tachycardia, vomiting, and palpitations. There's also a risk of, guys, how many times have we seen this? Serotonin syndrome, hypertension, abnormal bleeding, angle closure glaucoma, and urinary retention. Drug-drug interactions. This is on NCLEX. Make sure you know this. Because of the increased risk of serotonin syndrome, this is like the 5th time we're hearing this, when the SNRIs are used with MAOIs, the combination should be avoided. We are not going to give SNRIs with MAOIs. Matter of fact, you don't give anything with the MAOIs, right? Because so many things are contraindicated. So make sure you guys also know those signs and symptoms of serotonin syndrome. Any substance that is serotonergic, such as your triptans, your tricyclics, fentanyl, lithium, tramadol, tryptophan, buspirone, amphetamines, and St. John worts, all of these can increase the risk of serotonin syndrome. This looks like a beautiful select all that applies to me. There's increased risk of bleeding if these medications are combined with aspirin, NSAIDs, and antiplatelet drugs or other drugs that affect coagulation. Key points. The SNRIs prevent the reuptake of primarily serotonin and norepinephrine. We've seen that a million times. The side effects of this classification are related to the potential serotonergic and non-adrenergic activity. There's a black box warning about increased suicidal thoughts and behaviors in children, adolescents, and young adults. Other antidepressants, you guys can read this on your own, but I want to bring the Wellbutrin to your attention. It weakly blocks the reuptake of norepinephrine, 5-HT, and dopamine. At lower doses, this drug is effective in smoking cessation. This is the 2nd or 3rd time we're seeing this. It does enter breast milk, and it shouldn't be used by nursing mothers. So when it comes to depression and smoking, this medication is the drug you should be expecting that doctor to order. Page 371. The adverse effects of TCAs are sedating and anticholinergic. Those of MAOIs are CNS related. I'm sorry, did you say something? Is that better?
Thank you.
No problem. The MAOIs are CNS related and sympathomimetic, and the adverse effects of the SSRIs are fewer, but they do cause CNS changes. Remember, the SNRIs have serotonergic and non-adrenergic effects. Every single one of these antidepressant drugs have a black box warning of the risk of suicidality, especially in children, adolescents, and young adults. All right, Chapter 22, Psychotherapeutic Drugs. Key terms, antipsychotics. These are drugs that treat disorders involving thought processes. Dopamine receptor blockers. Remember, guys, when a patient is psychotic, they're in psychosis. That means they're out of touch with reality. So the antipsychotic drugs block the dopamine receptors. ADHD, this is a behavioral syndrome characterized by an inability to concentrate for longer than a few minutes and excessive activity. Bipolar disorder. It's a behavioral disorder that involves extremes of depression and alternating with hyperactivity and excitement. So the patient goes from one extreme to the other. They're depressed, they don't want to get out of bed, they got the curtains drawn, the lights are off, they don't even want to eat, they're not interested in anything. And they go from that end of the spectrum to hyperactivity, where they're excited about everything, where they're impulsive. Okay? When they're in that stage, many of them, they'll tend to give away their money or gamble, or they'll make sexually irresponsible decisions. Yes, that's the manic phase of bipolar disorder, okay? Mania, that's the state of hyperexcitability. What did I write here? Think, nutrition, fluid, okay. So when it comes to mania, guys, when NCLEX is asking you about mania, very often what they're trying to pull from you is that you understand when the patient's in the manic state, your priority is going to be what keeps them alive. Nutrition. Because that patient's going. They don't even want to stop to eat. So that type of patient, you're going to give them a finger food, you're going to give them a sandwich, you're going to give them something that they can eat while they're on the run, because they are not going to stop to sit down and have a dinner, eat mashed potatoes and steak or whatever. So you got to give them finger foods, right? Give them a bottled water, because they're not going to stop to drink. So they're going to drink while they're running all over the place. You need to think fluid electrolytes, nutrition, rest. You have to force them to rest, because if a patient doesn't rest, they're going to collapse. Think of Maslow's hierarchy of needs. Everything that falls under physiological integrity that is keeping that patient alive, that's going to be your priority for the patient that's experiencing mania. Narcolepsy, that's a mental disorder characterized by daytime sleepiness and periods of sudden loss of wakefulness. And then schizophrenia. This is the most common type of psychosis. It's characterized by hallucinations, paranoia, delusions, speech abnormalities, and affective problems. All right, drug cards. Your first one are going to be your typical antipsychotics. I put a star next to the most important ones you need to know. Those are the ones that tend to show up, on your, the NCLEX, ATI. Make sure you know your chlorpromazine, fluphenazine. This Haldol, you better know it, like the back of your hand. I promise you're going to see it again. Your second drug card is going to be your atypical antipsychotics, especially clozapine. Make sure you know it. Risperidone, ziprasidone. Your third drug card you're going to give me are drugs for bipolar disorders, especially lithium. Make sure you know lithium like the back of your hand. Fourth drug card, your Cns Stimulants, atomexetine. This drug, I'm not going to try to pronounce it. Someone pronounce this drug for me? Guanfacine, thank you. Methylphenidate. Those three, make sure you know them like the back of your hand. All right, next page. All right, so antipsychotics. Even though they do not cure any psychotic disorders, psychotherapeutic agents do help both adult and pediatric patients function in a more acceptable manner and carry on activities of daily living. There's no cure, okay? These are just treatments. Mental disorders and their classifications. I cannot see. All right, diagnosis of a mental disorder is often based on distinguishing characteristics as described in the DSM-IV. First, let's start with schizophrenia. That's the most common type of psychosis. And remember, guys, when you see that word psychosis, all that means is being out of touch with reality. Characteristics of schizophrenia include hallucinations, paranoia, delusions, speech abnormalities, and affective problems. Bipolar disorder, that's extremes of depression alternating with hyperactivity and excitement. Narcolepsy, that's your daytime sleepiness and sudden periods of loss of wakefulness. This patient could be in the middle of a conversation with you and just fall asleep. ADHD, characterized by inability to concentrate on one activity for longer than a few minutes and a state of hyperkinesis. What does kinesis mean? Movement, yeah. All right, take a look at this box, 22.1. Psychotherapeutic agents. Let's start with children. Of the antipsychotics, chlorpromazine, haloperidol, pimazide, I hate this, prochlorperazine, risperidone, someone say this drug for me, you guys, I can't talk, thyrodazine, and this drug right here. You see it. These are the only ones with established pediatric regimens. You need to know this. These are the only antipsychotic drugs that you can give the kids. Okay? Lithium does not have a recommended pediatric dose, and the drug should not ordinarily be given in children. So you're going to try, you expect the physician to try these drugs first. Okay, you're going to question that order if they're trying to give lithium to a child. The Cns stimulants are often used in children to maintain various attention deficit disorders. But before they start those drugs, look at this, a baseline ECG should be done to rule out congenital heart problems. When these drugs were first introduced and given to children for ADHD, what we found, many of them ended up dying because they had a congenital heart disorder that was never diagnosed. And those meds actually just kind of threw them over the edge, and they ended up having some type of arrhythmic event. Okay, so it's very important before they start any of those drugs, we have to get an ECG done to know their baseline. Adults. The QT interval should be evaluated before thyroradazine or ziprasidone is prescribed and periodically during use. We're concerned about the heart for adults as well. Look at this. This is on NCLEX. Make sure you know this. Patients receiving lithium should be encouraged to maintain hydration and salt intake. Let me stop right there so I can explain this to you. Lithium has a very narrow therapeutic range, 0.6 to 1.2. Once that patient hits 1.5, they're toxic level, right? Sodium can cause the patient to have a toxic or subtherapeutic level. Remember how your sodium level is 135 to 145? So if it's more than 145, patient has too much sodium, it can cause the patient to have a decreased therapeutic level of the lithium. And if the patient's sodium is less than 135, it can cause the patient to have a toxic level of sodium. They have an inverse relationship, so you have to be very cautious. When it comes to lithium, it's very important to watch that sodium range and make sure you keep that patient hydrated, because if they're dehydrated, what do you think that's going to happen to that sodium level? Increase the sodium level, which will do what to the lithium level? Decrease it. That's very important, and NCLEX expects you to understand this, okay? These drugs should be used cautiously during pregnancy and lactation because of the potential for adverse effects on the fetus or neonate. Women of childbearing age who need to take lithium should be advised to use barrier contraceptives while taking the drug because of the potential for serious congenital abnormalities. That's on NCLEX as well. You're expected to know it. Vince, I gave you a shout out on my video yesterday. Yeah, I had to put my phone on the focus thing you taught me.
Oh, yeah.
What's that? Yeah. I was like, good looking out, Vince. Thank you. It was part 1 I did acid-base balance. No, part 2.
Was it on your TikTok?
No. My YouTube. Yeah.
I'm famous now, guys.
All right, older adults. Older patients may be more susceptible to the adverse effects of these drugs. And you guys know that because remember, in the older adults, the liver's not working the way it's supposed to or used to, kidney's not working the way it used to. So they need a smaller amount of the same medication you give to a younger person to reach that therapeutic effect, because that drug is going to stay in their system longer. It takes longer for that drug to be metabolized, for it to be broken down, and it takes longer for that drug to be excreted from the body of an elderly patient, okay? So it makes sense. All doses need to be reduced and patients monitored closely for toxic effects and to provide safety measures if CNS effects do occur. They should not be used to control behavior with dementia. If you do that, that's battery. You are chemically restraining the patient, okay? Patients with renal impairment should be monitored closely while taking lithium, because obviously if those kidneys aren't working, that medication is going to stay in their body a lot longer and they're more at risk for a toxic level. Decreased doses may be needed. They should be urged to maintain hydration and salt intake, which can be a challenge with some older patients. Remember, the geriatric patients, they lose their sense of thirst. That's why you have to very often remind them to take sips of water. That's why you put a straw in their cup, so it'll be easier for them to take those sips. Prolongation of the QT interval associated with use of thioridazine or ziprasidone may be a concern in the elderly patients with coronary disease. So we're going to be very careful with those elderly patients, especially if they have heart disease. Antipsychotic neuroleptic drugs. The antipsychotic drugs, which are essentially, this is the third time I'm seeing this, guys, dopamine receptor blockers. So blocking those dopamine receptors helps with the patient who's experiencing psychosis. Because of their associated neurological adverse effects, these medications are also called neuroleptic agents. So when they say antipsychotic neuroleptic agents, they're talking about the same thing. At one time, they used to be called tranquilizers, not anymore. All right, therapeutic actions and indications of the antipsychotic drugs. The typical antipsychotic drugs, again, block dopamine receptors. They depress the RAS, limiting stimuli coming to the brain. They also have anticholinergic, antihistamine, and alpha-adrenergic blocking effects, and all of those are related to blocking the dopamine receptor sites. The antipsychotics are indicated for schizophrenia and for manifestations of other psychotic disorders, including, look at this list, guys, that's a beautiful select all that applies to me. Hyperactivity, combative behavior, severe behavioral problems. So it didn't just say behavior problems, right? Severe behavioral problems in children for short-term control. Some of them are also approved for the treatment of bipolar disorder. Chlorpromazine, one of the older antipsychotics, is also used to decrease pre-op restlessness and apprehension. And that makes sense. Before surgery, you're going to be really, really nervous, right? To treat intermittent porphyria as an adjunct in the treatment of tetanus and to control nausea, vomiting, and intractable hiccups. And I made a note to the side. What did I write here? Oh, okay, for the porphyria, that's having too much porphyrin. It helps hemoglobin. That's a side note I made. Anyway, Haldol, haloperidol, this is frequently used to treat acute psychiatric situations, and it's available for IV use when prolonged parenteral therapy is required. So if the patient is actively psychotic, we have an acute situation, this is the drug most likely that's going to be ordered for this patient, the haloperidol, also known as Haldol, okay? Prochlorperazine is also frequently used to treat severe nausea and vomiting associated with surgery and chemotherapy. Today is just not my day. Someone pronounce that drug? Aripiprazole, one of the newer and atypical antipsychotics, has been found to be effective in treating schizophrenia, major depressive disorder, and bipolar disorders, and it's been used parentally for the treatment of acute agitation associated with these disorders. Lurasidone, the newest of the atypical antipsychotics, is used for adults with schizophrenia. Olanzapine and ziprasidone are also used for bipolar disorders and parentally to treat acute agitation. Risperidone is used frequently to treat irritability and aggression associated with autistic disorders in children and adolescents, as well as acute manic episodes for bipolar disorders. A patient who does not respond to one drug may react successfully to another agent. Responses may also vary because of cultural issues. Here's the thing, guys. If a patient started on an antipsychotic drug, you do not expect the psychiatrist or the physician, the NP, whatever, you don't expect that practitioner to switch the drug until that patient's been taking the drug for a good 2 months. Because remember, it takes a minimum of 4 to 6 weeks before we start to see a therapeutic effect. So it really takes time for that drug to be circulating in their system for them to be able to deem, okay, this drug really isn't working, let's switch them to something else. So this is absolutely true. What one drug may not work for a patient, another drug will. Yes, that's true, but we're not going to be switching them in a couple of weeks. It's going to be a couple of months before they make that determination, okay? Pharmacokinetics. Intramuscular does provide 4 to 5 times the active dose as oral doses. So when you give this antipsychotic IM, it's much more potent when than if you give it orally. Okay? So caution should be required if one's switching between routes. You can't just go from oral to IM. You have to do it very cautiously. The antipsychotics are widely distributed in the tissues and are often stored there, being released for up to 6 months after the drug is stopped. So think about it. If the patient's getting this drug, this antipsychotic drug IM, right? Can we start them on another antipsychotic drug 2-3 weeks afterwards? No, because when they get the IM, it could stay in their system for 6 months. So we have to be very careful. Clinical effects may not be seen for several weeks, and patients should be encouraged to continue taking the drugs even if they see no immediate effectiveness. Teach them in advance. You are not going to start to feel better right away. It's going to take several weeks. So keep taking the medications as ordered. Contraindications and cautions. Antipsychotic drugs are contraindicated in the presence of underlying disease that could be exacerbated by the dopamine blocking effects of the drugs. They're also contraindicated in these conditions. If the patient has CNS depression, if they have circulatory collapse, if they have Parkinson's disease, and we're going to talk about that shortly, if they've got coronary disease, severe hypotension, bone marrow suppression, blood dyscrasia, prolongation of QT interval is a contraindication to the use of mesorzidine, thiodorazine, and ziprasidone. Why? Because those 3 drugs already can cause QT interval issues, right? So it doesn't make any sense that we would give these type of medications to the patients. Does that make sense? All right. Antipsychotics are contraindicated for use in elderly patients with dementia because the use associated with an increased risk of cardiovascular effects and death. Before we move, well, actually, let's move on. I'll go back to this box in a second. Let's go to page 379. Caution should be used in the presence of medical conditions that could be exacerbated by the anticholinergic effects of the drugs. Because remember, these antipsychotic drugs do have anticholinergic effects. So where would it be contraindicated? If the patient has glaucoma, peptic ulcers, urinary or intestinal obstruction. In addition, care should be taken in patients with seizure disorders because the threshold for seizures could be lowered in patients with thyrotoxicosis. That means it would be much easier for a patient to have a seizure. Also, active alcoholism. Other situations that warrant caution include myelography within the last 24 hours or scheduled within the next 48 hours. That's on NCLEX. They expect you to know that. If a patient is expected to have a myelography, which means we're going to be using that contrast dye, if they had it within the past 24 hours or scheduled within the next 48 hours, it's contraindicated. We're not going to give that drug. Pregnancy, lactation. Because children are more apt to develop dystonia from the drugs, which can confuse the diagnosis of Ray's syndrome, caution should be used with children younger than 12 years of age who have CNS infection or chicken pox. The use of antipsychotics may result in bone marrow suppression, leading to blood dyscrasias, so care should be taken in patients who are immunosuppressed and who have cancer. That's on NCLEX as well. You're expected to know that. Adverse effects. The adverse effects associated with antipsychotic drugs are related to their dopamine blocking, anticholinergic, antihistamine, and alpha adrenergic activities. So 5 times already, in different ways, they told us what type of activities these antipsychotics have. Dopamine blocking, anticholinergic, antihistamine, and alpha adrenergic activities. That looks like a select all that applies to me. The most common CNS effects are sedation, weakness, tremors, drowsiness, extrapyramidal side effects, pseudo-Parkinsonism. Pseudo means fake, then Parkinsonism. So the patient is exhibiting those signs of symptoms of Parkinsonism, but they really don't have it, okay? Dystonia, akathisia, tardive dyskinesia, and potentially irreversible neuroleptic malignant syndrome. And we're going to talk about that in a second. Anticholinergic effects include dry mouth, nasal congestion, flushing, constipation, urinary retention, impotence, glaucoma, blurred vision, photophobia. This is on NCLEX. Make sure you know this. Blocking of dopamine leads to an increase in prolactin levels and subsequent gynecomastia. That's that breast development and occasionally milk production. Wouldn't that be something important to know for the male patients? Okay. This can be a concern, especially for male patients taking these drugs, and they should be advised of the possibility. Cardiovascular effects, which are probably related to the dopamine blocking effects, include hypotension, orthostatic hypotension, cardiac arrhythmias, congestive heart failure, and pulmonary edema. Several of these agents are associated with prolongation of QT interval, which could lead to serious or even fatal cardiac arrhythmias. Patients receiving these drugs should have a baseline and periodic ECG during therapy because of effects on the heart. All of the atypical antipsychotics include warnings that there's a risk for the development of diabetes mellitus and weight gain when these drugs are used. Ziprasidone has been associated with serious to fatal skin reaction and the systemic symptoms of DRESS. That's drug reaction with eosinophilia and systemic systems. When patients are maintained on any of the antipsychotic drugs, they should be monitored regularly for the signs and symptoms of diabetes. Respiratory effects of antipsychotic drugs. Laryngospasm, dyspnea, bronchospasms can occur. The phenothiazines often turn urine pink to reddish brown as a result of their excretion. That's important to teach the patient. It has no clinical significance. Bone marrow suppression is a possibility with some antipsychotic agents. Drug-drug interactions. The combination of antipsychotics with beta blockers can lead to an increase in the effect of both drugs. This combination should be avoided if possible. So giving antipsychotic with beta blockers can potentially cause a patient to have toxic levels of both the beta blockers and the antipsychotics. Antipsychotic alcohol combinations result in increased risk of CNS depression. Do we ever give alcohol with any drugs? No. And antipsychotic anticholinergic combinations lead to increase anticholinergic effects. And it makes sense because remember, the antipsychotic drugs by themselves have anticholinergic effects. So why would you give an antipsychotic drug along with an anticholinergic drug? It doesn't make any sense. Patients should not take thioridazine or ziprasidone with any other drug that's associated with prolongation of the QT interval, because those drugs already increase the QT interval. There are 2 medications that are approved to treat one of the side effects of antipsychotic medications. That's your tardive dyskinesia. They are, and these are the 2 drugs. You guys see them. Make sure you know them. I'm not going to try to pronounce them. Let's jump back to page 378. Look at box 22.4. Some important things for you guys to know. I know it's heavy. I know. Antipsychotic drugs and drugs for bipolar disorders. We're going to go over this box and the figure on the next page. I'll give you guys a break, okay? So just hang with me. The ways in which patients in certain cultural groups respond to antipsychotic drugs may vary. Let's start with African Americans, and this has been seen on NCLEX. For African Americans respond more rapidly to antipsychotic medications and have a greater risk for development of disfiguring adverse effects, such as tardive dyskinesia. These patients should be started off at the lowest dose possible. African Americans also display a higher red blood cell plasma lithium ratio than Caucasians do, and they report more adverse effects from lithium therapy. They have a higher potential for lithium toxicity at standard therapeutic ranges. Now we're going to talk about patients from Asian countries, such as patients from India, Turkey, Malaysia, China, Japan, Indonesia. They receive lower doses of neuroleptics and lithium to achieve the same therapeutic response as seen in patients in the United States. Arab American, they require lower doses to achieve the same therapeutic effects as Caucasians do. The nurse should carefully assess for herbal use and be aware of potential interactions. All right, next page. Figure 22.2. You see how I wrote this in big letters? No, NCLEX. This is on NCLEX. You absolutely must know this, guys. Let's start with A. So figure 22.2, this goes over common neurologic effects of the antipsychotic drugs. A, right here, dystonia, spasms of the tongue, neck, back, and legs. And so with dystonia, what we're really concerned is about what? Aspiration. B, look at this picture. That's akathisia, continuous restlessness, inability to sit still, constant moving, foot tapping, hand movements can be seen. So when it comes to akathisia, what we're really concerned about is what? Safety. So if you get a test question, and in the test question they tell you patients got dystonia, well, you're going to be concerned about aspiration. If the test question is talking to you about the akathisia, you're really going to be concerned about safety. Look at this one. Look at C. See, that's that pseudo-Parkinsonism. Pseudo-fake Parkinsonism. So they're displaying those signs and symptoms of Parkinsonism, but they really don't have Parkinsonism. Okay? And remember in Parkinsonism, the patient's doing this right here? Oop. They're doing this. They got a shuffling gait, right? And while you have this, you have the shuffling gait. You're doing this, and your arms aren't swinging the way that they're supposed to, right? Your equilibrium's going to be messed up. It's very easy for that patient to fall over. So for that patient, we're going to be concerned about safety. Something else we're going to be concerned about is going to be aspiration. Because besides that shuffling gait, They tend to what? Drool. Look at this figure. D. Tardive dyskinesia, that's abnormal muscle movements such as lip smacking, tongue darting, chewing movements, slow and aimless arm, leg movements. We're going to be concerned about safety, and we're going to be concerned about aspiration. Okay, take a 10-minute break, and then we'll start on page 381. Testing. Well, you can't be done yet. This stuff's on your final. You got to know it. Yeah, you guys have senioritis. What's tomorrow? Oh.
I was like, you already know.
Yeah. All right, so guys, page 381, nursing considerations for patient receiving antipsychotic and neuroleptic drugs. Always, you're going to assess them for contraindications, such as allergies, increased QT interval, diabetes, depression, urinary or intestinal obstruction. Make sure you go through that list. You're going to take their vitals. You're going to make sure you look at the labs. Make sure ECG is performed if appropriate. Do not allow patients to crush or chew sustained release capsules. Are you ever supposed to crush or chew capsules anyway? No. If administering parental forms of the antipsychotic drug, keep patient recumbent for 30 minutes. Why? We want to reduce that chance of them having orthostatic hypotension. Consider warning patient or patient's guardians about the risk of development of tardive dyskinesias with continued use. Caution the patient or guardians about the risk of gynecomastia when using these drugs. Make sure you're monitoring the CBCs because remember, blood dyscrasias is an adverse effect that we have to watch out for. Monitor the blood glucose levels because remember, diabetes is an adverse effect we have to watch out for. Make sure that you arrange for a gradual dose reduction after long-term use. And that's across the board, guys. When it comes to these psych meds, you can never DC the drug, what's the word I'm looking for? It starts with the A? Abruptly, thank you. You can never DC abruptly, okay? They have to be weaned off. Provide positioning of legs and arms to decrease discomfort because of that tardive dyskinesia. Remember, they're going to have the irregular movements. Provide sugarless candy and ice chips. Why do you think sugarless candy and ice chips? What is the effect of these drugs? Diabetes, anticholinergic, yes. So it has, remember, these drugs have the anticholinergic effects, so it causes dry mouth, right? But these drugs also make the patients prone to developing diabetes. So you don't want to give them just regular sugar with candy. That's why it has to be sugar-free. Encourage them to void before taking the drug. Remember the anticholinergic effects. You want to do safety measures such as side rails up, make sure they move slowly to decrease risk of orthostatic hypotension, provide for visual examinations to determine any ocular changes that could have occurred, and caution the patient that it will take several weeks before we start to see desired clinical effects. Warn them in advance. Lots and lots and lots of NCLEX concepts come from this page right here that we talked about. On page 382, this is a case study, a scenario. You guys can read that on your own. And pay special attention to the nursing implementation and the patient teaching. These are all for antipsychotic drugs. Everything in this situation we've talked about already. It's just reiterating that. Key points. Schizophrenia, again, is the most common psychosis in which delusions and hallucinations are what? Hallmark. Anything when you're reading and it says it's a hallmark or it's classic, you better know. Antipsychotic drugs are generally dopamine receptor blockers. Antipsychotics can cause hypotension, anticholinergic effects, sedation, extrapyramidal effects, including Parkinsonism, ataxia, and tremors. Okay, we're going to switch gears. Now we're going to go from antipsychotic to drugs treating bipolar disorders. Mania, at the opposite pole from depression, occurs in individuals with bipolar disorder who experience periods of depression followed by a period of mania. The mainstay for treatment of mania has always been what? Lithium. That is our go-to drug. Today, many other drugs are used successfully in treating bipolar disorders, including, guys, here are the list, make sure you know them. Lithium salts, such as Lithobid, are taken orally for the management of manic episodes and prevention of future episodes. This is on NCLEX, make sure you know it. The therapeutically effective serum level is 0.6 to 1.2. By the way, if you don't see this again when you guys get to your psych rotation, my name is not Professor D. I promise you're going to get at least one test question on this. You have to know that therapeutic level, okay? Pharmacokinetics. I know you guys hate me today because I got NCLEX all over these chapters, right? Yeah. During periods of sodium depletion or dehydration, the kidney reabsorbs more lithium into the serum, often leading to toxic levels. You have to know that. So when the sodium's high, the lithium's what? Low. When the sodium's low, the lithium is high. Very good. Therefore, patients must be encouraged to maintain hydration while taking this drug. They cannot afford to become dehydrated. Cautions and contraindications. If there's any hypersensitivity or allergy to lithium, it's contraindicated in the following conditions: significant renal or cardiac disease, a history of leukemia, metabolic disorders, including sodium depletion, dehydration, diuretic use, and again, hyponatremia leads to lithium retention and toxicity. Pregnancy and lactation are also contraindicated. Breastfeeding should be discontinued while on lithium. Women of childbearing age should be advised to use birth control while taking these drugs. Caution should be used in any condition that can alter the sodium levels, such as protracted diarrhea or excessive sweating, because obviously if you're sweating a lot or you have diarrhea, you're losing your sodium out one way or the other, right? In suicidal or impulsive patients, and in patients who have infection with fever. So let's look at the adverse effects. Remember, your therapeutic range is 0.6 to 1.2, right? All right. So serum levels of less than 1.5. What are the adverse effects that we can see? CNS problem including lethargy, slurred speech, muscle weakness, fine tremors, polyuria, nausea, vomiting, diarrhea. Serum levels of 1.5 to 2. Intensification of all of the foregoing reactions with ECG changes. So everything that we just talked about, that, you know, muscle weakness, the fine tremors, the slurred speech, all of those, but on top of that, we can start to see those ECG changes. Serum level of 2 to 2.5. Progression of the CNS effects that we already talked about to ataxia, clonic movements, hyperreflexia and seizures, possible cardiovascular effects such as severe ECG changes, hypotension, large output of dilute urine secondary to renal toxicity, fatality secondary to pulmonary toxicity. And now, if it's more than 2.5, complex multi-organ toxicity with significant risk of death. So how about we just keep it between 0.6 and 1.2, right? Everyone will be happy. Drug-drug interactions. Some drug-drug combinations should be avoided. A lithium haloperidol combination may result in encephalopathic syndrome consisting of weakness, lethargy, confusion, tremors, extrapyramidal symptoms, leukocytosis, and irreversible brain damage. So are we ever going to give a patient lithium and haloperidol? No. Very good. If lithium's given with carbamazepine, increased CNS toxicity can occur. Thiazide diuretic and lithium combinations increase the risk for lithium toxicity. And that makes sense, guys, because the patient's taking thiazide diuretics, they're getting rid of fluid and also getting rid of what? Sodium. That can cause the lithium level to be increased. It makes sense. If lithium's combined with indomethacin or with some NSAIDs, higher plasma levels of lithium can occur. Take a look at this, box 22.6. Patients being treated with lithium should be encouraged not to use herbal therapy psyllium, which is used to treat constipation to lower cholesterol levels. If this agent is combined with lithium, the absorption of lithium may be blocked and the patient will not receive therapeutic levels. All right, nursing considerations for patients on lithium. You're going to assess for contraindications such as allergies, dehydration, cardiovascular disease, sodium depletion, diuretics, protracted sweating, diarrhea, suicidal or impulsive patients with severe depression, pregnancy, lactation, infection with fever. You're going to take their vitals, including temperature, skin color, lesions, check them for lesions. Implementation rationales. You're going to monitor for toxic levels. Administer the drug with food or milk to alleviate GI irritation. Arrange to decrease dose after acute manic episodes. Why? Lithium tolerance is greatest during the acute episodes and decreases when the acute episode's over. Make sure that the patient maintains adequate intake of salt and fluid to decrease the risk of toxicity. You're going to monitor their clinical status closely. Arrange for small, frequent meals. Give sugarless lozenges to suck and frequent mouth care. Provide safety measures. You're going to provide patient teaching. Key points. Lithium, this is the standard anti-manic drug. This is our go-to drug when it comes to bipolar disorder mania, okay? Because it is potentially a very toxic salt, serum levels must be carefully monitored to prevent severe toxicity. Many other CNS drugs, including many of the atypical antipsychotics, are now approved for the use in bipolar disorder. Okay, so we were talking about, lithium drug use for the manic phase of bipolar disorder. It basically would bring that patient back down, right? Now we're going to switch gears. We're going to talk about CNS stimulants, drugs that do the opposite, that actually stimulate the CNS. CNS stimulants are used clinically to treat both ADHD and narcolepsy. Remember narcolepsy, that's the one where the patient could be in the middle of a conversation, they just fall asleep. Okay, so these drugs are CNS stimulants. Paradoxically, remember when you see that word paradoxically, that means ironically, right? Paradoxically, these drugs calm hyperkinetic children and help them focus on one activity for a longer period. And that is ironic because you would think a patient that is hyperactive, we try to give them something that would decrease the CNS, but actually giving them something that stimulates the CNS calms them down. CNS stimulants that are used to treat ADHD and narcolepsy include the methylphenidate, that's your Ritalin, thank you, Ritalin, Concerta, and others. If I had the time in my crazy schedule, I'd get speech therapy as an adult. I just don't have the time. All right, paradoxical effect of the calming excitability through CNS stimulation seen in attention deficit syndrome is believed to be related to the increased stimulation of an immature RAS, which leads to the ability to be more selective in response to incoming stimuli. That's what we think. We're not 100% sure. All we know is that these patients that have these excitability disorders, giving them CNS stimulants helps calm them down. Most of these drugs are controlled substances. It is important to include that point in the teaching plan. The drug should be secured at home to prevent inappropriate use or distribution. Because you better believe you have a dinner party and you have some guests over, you might have one guest that might see that rhythm and be like, oh, I can use this to lose some weight, or oh, I can use this to be more active in my job so I can get more done during the day. It's abused very often, okay? So make sure you have it locked away. In 2015, lisdexamfetamine was also approved for the treatment of binge eating disorders in adults. It carries a black box warning that it's not approved for weight loss. Contraindications and cautions. Known allergy to the drugs. Other contraindications include marked anxiety, agitation, tension, and severe fatigue or glaucoma. Pregnancy and lactation. Caution should be used in patients with a history of seizures, patients with a history of drug dependence, because remember, this drug is often abused, right? So you have to be careful of a person who already has a history of drug dependence. And when I say drug dependence, guys, that includes alcohol use, okay? Drug dependence, including alcoholism. In patients with hypertension. Why do you think it would be contraindicated in a patient with hypertension? There you go. It excites everything. Exactly. All right. Adverse effects include nervousness, insomnia, dizziness, headache, blurred vision, difficulty with accommodation. GI effects include anorexia, nausea, and weight loss may occur. And many people that abuse this drug is because for weight loss. Okay. Cardiovascular effects include hypertension, arrhythmias, angina. Sudden cardiac death has been associated with the use of these drugs. Sudden cardiac death. Studies have showed that the majority of these deaths occurred in children with undocumented cardiac defects. Because of this, a baseline ECG should be done before beginning therapy. For every single person that's going to be started on this drug, an ECG baseline has to be done. Skin rashes are a common reaction to some of these drugs. Physical and psychological dependence may also develop. Again, these drugs are controlled substances. Atomoxetine, which does not show dependence development, is not a controlled substance. The adverse effects associated with this drug are mainly anticholinergic, your dry mouth, constipation, nausea, urinary hesitancy. Guanfacine may cause sedation, dry mouth, constipation, and impotence, but it has not been associated with cardiovascular effects or dependence. Drug-drug interactions. A combination of CNS stimulant with an MAOI leads to increased risk of adverse effects. It also leads to increased toxicity and should be avoided if possible. We don't want to give anything with MAOIs. Just make it a rule of thumb, right? Likewise, the combination of CNS stimulant with guanethidine results in a decrease in antihypertensive effects, and it should be avoided. The combination of CNS stimulants with Tcas or Dilantin leads to a risk of increased drug levels. Nursing considerations for the patients receiving CNS stimulants. We're almost done, guys. Hang on. We're going to assess the patient for any known allergies, glaucoma, anxiety, tension, fatigue, seizure disorder, cardiac disease, hypertension, pregnancy, lactation, history of leukemia, history of drug dependency, including alcoholism. I should have highlighted the drug dependency because that shows up more than once. History of drug dependency, including alcoholism. Make sure you take the patient's vitals. Ensure proper diagnosis of behavioral syndromes and narcolepsy, because these drugs should not be used until underlying medical causes of the problem are ruled out. Imagine treating the patient for behavioral syndromes and they had a tumor, or it was really something else that was going on with the patient, okay? Arrange to interrupt the drug periodically in children who are receiving the drugs for behavioral syndromes to determine whether symptoms recur and therapy should be continued. Arrange to dispense at the least amount of drug possible. Why? We want to minimize the risk of overdose and abuse. You don't want that patient to be at home where mom's going, 1 for you, 2 for me. This is a big one. Make sure you know it. You're going to administer the drug before 6 p.m. Why? We want them to sleep at night, right? Go ahead.
I was just saying, why not just say take it early in the morning, especially with Adderall?
Yeah. Adderall, you want it early in the morning so it works during the day, and you want it to you want them to have time for it to wear off. I don't know. Listen, there are so many things in this book that I don't like. You're absolutely right. But it needs to be taken early in the morning before that child goes to school. Okay? Monitor the weight, CBC, and ECG to ensure early detection of adverse effects and proper intervention. You're going to consult with the school nurse or counselor to ensure comprehensive care of school-aged children receiving CNS stimulants. Provide safety measures such as side rails and assistance with ambulation as CNS effects occur. Provide thorough patient teaching. Monitor for adverse effects and evaluate effectiveness of teaching plan. Look at box 22.7, school nursing and Ritalin administration. It's no surprise that the use of Ritalin has increased dramatically. Because this drug needs to be given 2 or 3 times each day, it has become the responsibility of the school nurse to dispense the drug during the day. You guys can read the rest, but I wanted to bring that to your attention. Summary. Schizophrenia is characterized by delusions, hallucinations, and inappropriate response to stimuli. Bipolar disorder is a behavioral disorder that involves extremes of depression alternating with hyperactivity and excitement. An attention deficit disorder is a behavioral syndrome characterized by hyperactivity and short attention span. Remember, guys, when you see that word syndrome, that just means cluster of signs and symptoms that lead to a particular diagnosis, okay? Narcolepsy is a disorder characterized by daytime sleepiness and sudden loss of wakefulness. Lithium is the standard anti-manic drug. Because it is potentially a very toxic salt, serum levels must be monitored. The lithium level, what do we want that lithium level to be? Very good, 0.6 to 1.2. Sodium level, what do we want that to be? Yes, 135 to 145. Very good. CNS stimulants are used to treat ADHD and narcolepsy. These drugs improve concentration and the ability to filter and focus incoming stimuli.